A 6-year-old girl is brought by her mother with a 6-month history of recurrent vaginal discharge. The discharge is described as foul smelling and occasionally blood stained and has not responded to multiple courses of oral antibiotic prescribed by the GP. The child does not complain of itching or dysuria. On examination, the vulva appears mildly inflamed with irritant vulvitis, and a pool of purulent discharge is seen near the posterior faucet. No mass is visible externally. The child is otherwise well and afebrile. What is the most appropriate next step in the management? So, in this case, this is a case of, I think, foreign body. So, vaginoscopy under GA.
Yes, correct. You have identified very correctly, doctor. Basically, when you are reading at the same time, you are grabbing those important clues. Okay, and then look for the appropriate. That is why the EMQs, people find it difficult if you do not catch these clues. Okay, so vaginoscopy
Yes.
under general anesthesia. Okay, explanation is that recurrent offensive blood stain discharge is highly suggestive of vaginal foreign body. Foreign body will act as irritant, serve as a focus for infection. Vaginoscopy under general anesthesia is required because instrumentation in an awake child is painful and distressing, allows vaginal diagnosis and removal. Removal usually leads to complete resolution. Okay, so other options are not appropriate in this particular scenario. Just a moment, I'll take the slide up. Yeah, go ahead.
A 5-year-old girl presents with perineal itching, bursts at night. For the past 3 weeks, her mother reports disturbed sleep and frequent scratching. Recently, the child has developed vulvar soreness and a mild vaginal discharge. Examination shows excoriation around the perianal and vulval area with mild erythema. There is no blood stain discharge or offensive smell. The family lives in overcrowded accommodation. What is the most appropriate management? So, overcrowding and the
There is
itching at night,
overcrowding. Yeah.
perianal, yes, I want to, perianal scratching, especially at night, and overcrowding. I think they are all pointing toward the worm infestation. So, here, the mebendazole oral.
Yes, correct.
E,
So
e.
oral mebendazole is the treatment. So nocturnal perineal pruritus is classic for threadworms. So scratching leads to the excoriation, secondary inflammation and discharge. Then empirical mebendazole is appropriate when symptoms are characteristic, common in overcrowding, poor hygiene. Okay. So other
Yes.
options are not appropriate in this scenario. Just a
A
moment.
7 year
Yeah.
old girl of African origin presents with blood stained discharge noticed on her undergarment for 2 weeks. There is no offensive smell, itching, or dysuria. On examination, a circular erythematous donut shaped mass is seen protruding from the urethral meatus. The vaginal enteritis appears normal. What is the most appropriate first line treatment? So, this is a case of urethral this thing. And here, I think this topical estrogen cream will help. D.
Yes, correct. So your diagnosis is correct. Urethral prolapse. So topical
Right.
estrogen cream is the treatment of children. Surgery is not preferred there. Okay. So
So
urethral
common
prolapse,
in African
commoner in
origin.
girls of African origin, presents with bloodstained discharge. First line treatment is a topical estrogen. Surgery only if conservative treatment fails. Okay. The other options are not appropriate in this scenario. The next question, doctor.
An 8-year-old girl is referred with recurrent vaginal discharge and occasional bleeding. The discharge has persisted despite hygienic measures. A vaginal swab grows Neisseria gonorrhoeae. On examination, there are no obvious signs of trauma. The mother appears anxious and denies any concerns regarding abuse. What is the most appropriate next step? So, this is a, sir, I want to see the question. Can you just scroll
Yeah,
it
yeah.
down?
Just a moment.
Hmm.
Yeah. Yeah.
So she's a young girl with recurrent discharge, and vaginal swab shows uncommon bacteria like Neisseria gonorrhoeae, etc., and no obvious sign of trauma and mother is anxious. So this is a case of sexual abuse, and
So what
this
is the
in
next
this
step?
case, yes, just let me do the immediate referral for child protection assessment. F.
Yes, absolutely correct. So immediate referral for a child protection assessment. So Nigeria gonorrhea is a in a prepubertal child, automatic safeguarding referral is required. Absence of trauma is not a, absence of abuse. All trusts have mandatory child protection pathways. Okay, so other options are not appropriate in this particular scenario. So final take-home message is that offensive blood stain discharge, think of foreign body. Nocturnal itching, think of threadworms. Blood thin discharge plus African origin. Possibility of urethral prolapse we have to keep in mind. And STI organism, child protection referral always. Okay. So that finishes the questions on this particular talk article.